Medical news from European Heart Journal. Micro-axial flow pump versus veno-arterial extracorporeal membrane oxygenation for high-risk percutaneous coronary interventions, a randomized trial. Prophylactic support with a micro-axial flow pump during high-risk percutaneous coronary intervention, PCI, in patients with severely impaired left ventricular function proved to be at least as safe as veno-arterial extracorporeal membrane oxygenation, ECMO, while shortening hospital stay and reducing device-related complications. This finding offers a less invasive alternative for a cohort that traditionally faces high procedural mortality and morbidity. Patients with complex 3-vessel disease, unprotected left main lesions, or a solitary remaining conduit and a left ventricular ejection fraction of 35% or less are at heightened risk of hemodynamic collapse during PCI. Yet robust data guiding the choice of mechanical circulatory support, MCS, in this setting have been sparse. Prior studies have demonstrated the theoretical benefits of both microaxial pumps, which provide forward flow with minimal afterload, and ECMO, which offers full cardiopulmonary support but at the cost of increased afterload and bleeding risk. The uncertainty surrounding optimal device selection prompted a multi-center, prospective, randomized trial to directly compare these strategies. In this open-label, non-inferiority trial, 222 patients undergoing non-emergent, high-risk PCI were allocated to receive either the SynFlow 3.0 microaxial flow pump, N equals 109, or ECMO, N equals 113, as prophylactic support. The primary endpoint was a composite of 30-day major adverse events, encompassing all-cause mortality, myocardial infarction, stroke or transient ischemic attack, repeat revascularization, major bleeding, acute kidney injury, cardiopulmonary resuscitation or cardioversion, need for cardiac surgery or limb ischemia, and serious device-related complications. Safety outcomes included individual adverse events and serious adverse events. The trial was powered to demonstrate non-inferiority of the microaxial pump with respect to the primary composite endpoint, adjusting for center effects. At 30 days, major adverse events occurred in 8 of 109 patients, 7.3%, receiving the SynFlow 3.0 device versus 13 of 113 patients, 11.5%, in the ECMO arm, yielding an absolute risk difference of -4.6%, 95% CI -12.6 to 3.5, and a p-value for non-inferiority of less than 0.001. Hospital length of stay was modestly but significantly shorter after microaxial support, mean 4.1 days versus 5.2 days, p equals 0.047. Device-related adverse events were also reduced, 3.7% versus 11.5%, p equals 0.041, and anemia was less frequent with the microaxial pump, 9.2% versus 20.4%, p equals 0.023. No differences were observed in mortality, myocardial infarction, stroke, or acute kidney injury between groups. Subgroup analyses suggested that the benefit in reduced device-related complications was consistent across patients with left main disease versus 3-vessel disease, and across those with an LVEF less than or equal to 25% versus 2635%. However, the trial was not powered to detect differences in these strata, and the confidence intervals around subgroup estimates were wide. The results support the use of a microaxial flow pump as a first-line prophylactic MCS strategy for high-risk PCI in severely depressed left ventricular function, offering comparable safety to ECMO while mitigating bleeding and length of stay concerns. These data may prompt guideline committees to endorse microaxial devices as the preferred option when hemodynamic support is indicated, especially in centers where ECMO resources are limited or where rapid post-procedural recovery is a priority. Interpretation is tempered by several limitations. The open-label design could introduce bias in. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.